Hello.
Oh, hi, Dr. Chen. I just introduced you, so welcome. I'm glad you were able to get connected. And I know that you have a time constraint at 11, so maybe if you could get us started on your neighborhood disparities and COVID study.
Sure. Yeah. Actually, before my talk, I will share something. So actually, it's part of my talk. I'm a statistician instead of epidemiologist. So this study is really, I twist my arm. The whole reason is back to 2020 when the COVID first kick in New York. It's really a mess. And as a parent, I worry a lot. Should I send my child to school? And so in the summer 2020, I have an idea. I say a lot of parents have the same concern as me. I would like to make the information about the COVID to be more transparent and easy to observe for lay public. So actually starting from June, I put together a group of few students in my department, and we start to work on a COVID dashboard for New York City. And this is the dashboard I share with the screen. And in this dashboard, people we do daily update for number of cases and also the deaths caused by the COVID. So we have the tab called the COVID-19 checker, and individuals can go there. You can see we stop update in this summer because now that's a concern to a lot of people. So we present information by zip code. So anyone in New York City, for example, in our Columbia Medical Center, our office is located 10032, and I click 10032, it comes up with information for our Washington Heights, and it give lay public a total number of cases. New cases happened yesterday, and so people can really to see what's going on for my neighborhood when they make the decision. We also try to show the COVID-19 distribution. We have a different outcome, and here it shows the total cases. Again, it's for June 2022, and you can see this map. Anywhere color in the blue is belong to part of New York City. We have a different zip code, and you can see the darker color represent the neighborhood that have more cases. So if you click on this neighborhood, and it can tell you the name of the neighborhood and total number of COVID-19 cases. If you're interested in that, you can do the same things again. And we also do the total number of tests. We show the distribution of the cumulative information for different boroughs. So in New York City, we have 5 boroughs. I will talk also in my study for the COVID for comparison of 2 waves. So basically for this information, we can see which demographic group are harder hit compared to the others. So for example, if you see for the total cases, the oldest age group, 75 and above, was not that bad. But if you see the death rate, they are more dominated, and also hospitalization rate. We also provide the trend, so you can always come to check your neighborhood for the past 1 month or even longer time. It takes some time to upload for the community for this dashboard because it's really heavy. We have a lot of information, but actually basically it will come out for the trajectory curve for each neighborhood. You can choose different neighborhoods associated with neighborhood, for example. We also do the projection to tell people for the next 8 weeks what the total number of cases would like. We also show the neighborhood's information. So I will stop sharing. The reason I presented this dashboard is because the work I'm going to talk today actually is based on the data from this dashboard. We collected the data, and then based on this data, we found a lot of important information, and we think some important analysis can be conducted too. So that's why I say I'm a statistician, but from this practice, it really helped me to understand better for the epidemiology, especially for the COVID pandemic. So now I will get back to my talk. As my title show, during this dashboard, we see a lot of neighborhood disparity. As I show you in the map, some neighborhoods have darker color compared to the other neighborhoods. And we want to know what's the reason cause this neighborhood disparity. When we work on the paper, we have access to the data of COVID-19 outcomes for the first two waves. The first wave is March to May 2020. And then the second wave is more from December 2020 to April 2021. And a lot of things change between these two waves because, for example, when the first wave hit the New York City, people barely have any knowledge about this virus. People didn't know like it's really serious. We need to wear masks. We need to maintain social distance. But when the second wave hit, people have a more educated and have more knowledge. So, and also a lot of strategy was implemented. So again, as I say, the background is as a major international hub and most dense population city in the United States, New York City becomes the epicenter of COVID-19 in April 2020. New York City is a very special place because we have a very unique demographic and social economic characteristics and spanned across these 5 different boroughs. In other studies, not COVID, it's already shown the neighborhoods across this borough play important roles in explaining health disparities in New York City. And in early 2020, we also see COVID-19 hospitalization and mortality varied across different boroughs and neighborhoods. And also the New York City went through multiple waves of COVID-19 outbreak. So objective of this study, we want to compare the association of a neighborhood demographic and socioeconomic characteristics with COVID-19 outcome in New York City across the first 2 waves of the outbreak. We consider 2 different outcomes. One is confirmed COVID-19 new cases based on PCR test, and the second one is COVID-19 related deaths. Why we want to study the comparison of this association across these 2 waves? Because we think the demographics and socioeconomic association with the COVID-19 outcome between these 2 waves hold important policy lessons. They may elucidate dynamics of health disparities as the pandemic evolved, and it can further inform the public health crisis planning, preparedness, and response. The study design, as I say, the data all come from the dashboard. So this is a retrospective study. We use neighborhood level data, including the COVID-19 outcomes and neighborhood characteristics in New York City. The study spanned from March 1st, 2020, when the first case was reported in New York City, until the end of the second wave we defined as April 30, 2021. The neighborhood here is defined by a residential area corresponding to a particular modified zip code tabulation area we call it ZCTA. ZCTA usually defined as a few adjacent sensor blocks, for example. The COVID-19 outcome were originally acquired from the New York City Department of Health and Mental Hygiene for COVID data GitHub. And for neighborhood information, we retrieved from US Census Bureau for 2019 American Community Survey 5-year estimates. So in this study, we don't include any individual person data set. The data is available in the ZCTA level. We define these 2 waves. The first wave is March 1st to May 31st, 2020. The second wave is not that well defined. We typically, based on the local news report, it started around Thanksgiving. So it's late November and early December to April 2021. But because the New York City Department of Health make some big modification to their database on December 7, 2020. So we decide to use the data starting from December 7, 2020 and end the second wave to April 30, 2021. The fourth wave, the variant of virus is the original virus, variant, and the second wave for New York City primarily is called the B.1.526 variant. We focus on two outcomes. The first one is total number of confirmed COVID-19 positive cases defined using PCR test. And then the second outcome is total number of COVID-19 deaths in each neighborhood during each wave reported as deaths related to COVID-19 by New York City Department of Health. We consider different neighborhood characteristics. The fourth one is a borough. We have 5 boroughs. They are Bronx, Brooklyn, Manhattan, Queens, Staten Island. We also have a percentage of residents age older or equal to 75 years, percentage of male residents, percentage of Black, Hispanic, Asian. We didn't include percentage of white because they will sum up to close to 100. So we need to leave one group out. Percentage of household with at least 4 members, because the study shows large and small households have some impact on the chance of infections and also deaths. Percentage of having high school graduate, percentage of having high health insurance and median household income for each GCTA. So all the measure is for the GCTA level, for neighborhood level. For statistical analysis, because it's count data, and so we use called a negative binomial model. Typically, when you have a count data, the first thing we will think about is, oh, I will use Poisson regression. But because Poisson regression have a very strong assumption, it requires the mean and variance of the data of the count to be the same. But in our data set, our data have more variation. So our variance actually larger than mean. In this case, in statistics, we typically recommend to use a negative binomial model instead of Poisson regression model. In addition, in this specific problem, we also see the spatial clustering. As I showed in the dashboard earlier, neighborhoods that are next to each other seem to be more similar in terms of the COVID outcomes. So in our analysis, we want to account for this spatial correlation. So at the end, we use a model called the Bayesian hierarchical spatial negative binomial model. With this model, we want to assess the association between each of the outcome and the neighborhood characteristics while accounting for spatial correlation between adjacent neighborhoods. We use a model called ICAP. So it's called intrinsic conditional autoregression. So you have a random effect, because with this one, it can allow us to account the correlations for the adjacent neighborhoods. So next slide, I will show you the model in case anyone in the audience who are really interested how the model look like. So we assume that each outcome is a count. It's a count total number of positive cases in this neighborhood, in this specific way, for example, follow a negative binomial distribution, and we assume they have a neighborhood and time specific rate. We call the mu IT, I to denote neighborhood I, T for denote wave T. And we also have variance function is mu IT plus alpha times the mu IT square. So you can see if alpha is positive, we allowed our variance to be larger than the mean, or this alpha is called over dispersion. You might heard about when you fit a Poisson regression model, and people might question if you have over dispersion. So if you have over dispersion, negative binomial model will be a better option. And the alpha is called over dispersion parameter, allowed us to account for over dispersion. So the model here is we model the log of the expected value of the count and this mu, and actually this mu we also for the write it as expected value of count divided by PIT. So what is PIT means? It's offset. Thinking about, we are talking about a count from different neighborhoods, but different neighborhoods have a different population size. We just compare their count. That's not a fair comparison. We need to account for the rate. That would be a better measure. So we need to divide the total number of count by the total population size in that neighborhood. On the right-hand side of the regression model, we have X to denote contain all the vector Y for intercept and all the covariate for the neighborhood level for neighborhood I at time t. And then you can see we also have another term called UI. This is arrow term, but this arrow term is typically different from what we typically see in regular regression model. It's because this is UI. We want to model the spatial structure, that the correlation between neighborhoods. So that's what we kick in this I-cup structure idea. So basically, for the residual effect of a neighborhood, we assume we follow a normal distribution. And the mean of this neighborhood distribution is the average of the mean value of this rate for all the surrounding neighborhoods. When we define the surrounding neighborhood, we define as the neighborhood that share a boundary with the neighborhood we are starting for the neighborhood I. So basic idea is, if I in a neighborhood, my neighborhood's mean effect, it will be sub-distribution, but the average should be equal to the average of all my surrounding neighborhoods. So that will guarantee my neighborhood in some way is similar to my nearby neighborhoods. I will skip the other notations because it will be too much if you don't have a statistics background, but this is an idea to show you how we account for the neighborhood spatial correlation, because we added this arrow term to allow the effect of my neighborhood to be similar to all the surrounding neighborhoods that have shared common boundaries. Okay. As I talk about each neighborhood, the count cannot be directly compared because they depend on different population. But that's not the only way we talk about it. We usually in the count model, we define a called offset. So for the model with the total conformed cases, we take this offset, in the previous slide, we called as this PIT, is called offset. When the outcome is total conformed positive cases, our offset is the neighborhood population size. So we can model the cumulative incidence rate in this neighborhood. But for the model with death count as the outcome, we're thinking about two different offsets. If we use the neighborhood population size as offset, then this ratio between the count and this offset ratio is interpreted as the death rate per capita. But if we use the conformed positive cases of the offset, so we say total number of count divided by total number of positive cases, then this is called a case fatality ratio. In each outcome, we fit a multiple model, we force fit a marginal model, we have a multivariate model, and then we also have an interaction model. Because of time concern, I will move on to the result section. So for the result, this table shows the comparison with all the neighborhoods in our study. In total is 177 neighborhoods. And you can see, for example, for the race variables, Manhattan is dominated by white, but if you look at the Bronx is dominated by Hispanic. and Queens is Hispanic and Asian, and also other value. For example, medium household income, Manhattan is really high, and Bronx is really low, right? So you can see really have disparity in terms of demographic and social economic variables for different neighborhoods in New York City. This shows the pattern of COVID-19 positive cases. The top two plot is the daily measure of the count. And so across all the neighborhoods, the total number of cases across time. For the part A is for wave 1, so it's from March to at the end of May in 2020. So you can see the peak in April for the cases. But by the end of May, it almost gone for the cases. But for the wave 2, it is pretty high across all time and peak in middle January. But even at the end of April, the case is still above 2,000 a day. For the bottom two plot shows the neighbor spatial information, but we sum up all the cases in the interval, the wave 1 and wave 2. So you can see some neighborhoods are much darker in the color compared to the others. This shows some disparity in COVID cases in the city. Similar plot, but it's for deaths as the count. And we know deaths have some delay compared to cases. So the peak for the deaths is middle April for the wave 1, and then mid-February for wave 2. And then also for the spatial distribution, you can see for the wave 1, a lot of disparity to see like some much darker than the other. And one interesting to show you is for wave 1, if you see this for positive cases, a lot of neighborhoods have a much darker color compared to the wave 1. And also for the daily sum, you can see it's a lot of cases. But when you look at the deaths, it's much lighter in the color, although we show here is high, but you look at the scale, the most of cases for the days with most deaths is about 100. But for the wave 1, the peak is about 600 people died due to COVID in the wave 1. And so you can see a lighter color in the wave 2. So wave 2 have much more cases compared to wave 1, but the death rate is much lower. This kind of show the correlation for the wave 1 and wave 2 between the incidence and death rate. So you can see it's highly correlated. So the neighborhood who are affected in wave 1 also are more likely to affected by wave 2. And so this is really interesting to see, because originally we hypothesized say in wave 1 the neighborhood was hit, they built immunity, and then immunity, but in the wave 2 they may less voluntary to the virus, but that's not true. The neighborhood who were harder hit in wave 1 continue to be harder hit in wave 2. This is a model results for incidence rate. So we first do the wave 1 analysis and wave 2 analysis. The result here is adjusted rate ratio. We also do the interaction effect to assess if this the effect change between wave 1 and wave 2. So you can see we use Manhattan as a reference group. The Queens, Staten Island, and Bronx all have an elevated rate of incidence rate of COVID compared to Manhattan for the wave 1. But this elevation was only seen in Queens and Staten Island. The Queens, the rate ratio also smaller than the wave 1. But it's interesting to see for the Staten Island is still very high for the wave 2. When we do the test, it only showed a significant reductions in Bronx. Bronx was significant higher in wave 1, but not in wave 2. And so it's a significant reduction because this rate ratio is less than 1. We also see the neighborhood with more male also have a higher rate, incidence rate in wave 1, but not in wave 2. The neighborhood with a higher percentage of senior people have a higher rate of incidence in wave 1, but not wave 2. the neighborhood with a higher percentage of Black population or Hispanic population have a higher incidence rate in wave 1, but not in wave 2. Also, neighborhood with a larger percentage of large households have a higher percentage of infection compared in wave 1, but not in wave 2. Insurance is no association, and but the income is a protective factor. So the neighborhood have a higher household income, have a low incidence rate for both wave 1 and wave 2. And actually the protection effect is even stronger in wave 2 compared to wave 1. Next, let's see for the model for death per capita. We see although Brooklyn did not have elevated incidence rate, but it have a higher death rate per capita. Queens is the same, but not Staten Island in wave 1. But for wave 2, Staten Island was badly hit both for the incidence rate and also death per capita. Gender is not affected in death rate, but the older adult, of course, we know like senior people are more affected. So the people with neighborhood with a higher percentage of senior people have a much higher death per capita for both wave 1 and wave 2. The community with a high percentage of Black have a higher rate ratio for wave 1 and also for Hispanic. But for the wave 2, we see this elevated death per capita in Asian, but not the other percentage. For the health insurance, individual with a neighborhood with a higher percentage of health insurance, we also have a lower rate of death per capita, and also the median household income is a protective risk factors for both wave 1 and wave 2. So household income is protective risk factors for both incidence rate and death per capita. The final model we would like to see is a case fatality ratio. So case fatality ratio means among those classified as positive, how many have the deaths as the event. And we see not much difference across neighborhoods. But we still see the neighborhood with a higher percentage of senior have a higher case fatality ratio. And actually this even higher in wave 2 compared to wave 1. The community with a higher percentage of Black have a higher case fatality for both wave 1 and wave 2. And the community higher percentage of Asian also have a higher rate case fatality ratio in wave 2. Household size now becomes a protective factor. The neighborhood with a higher percentage of large households have a lower case fatality ratio in wave 1. And also the health insurance play an important role in wave 1 in protect for the case fatality ratio. We don't see the median household income have an impact on the case fatality ratio. So I would like to summarize what we found. So neighborhood with a higher percentage of Black and Hispanic population have a higher incidence rate and death rate per capita relative to predominantly white neighborhood in wave 1, but not in wave 2. Neighborhood with a higher percentage of male older adults and larger households also have high incidence rate of COVID-19 in wave 1, but not wave 2. We think this change may be explained by the change in the risk perception and protective behavior among residents in this neighborhood to better protect themselves from infection. We also see change in boroughs. Queens, Staten Island, and Bronx have a higher rate of COVID cases than Wales and Manhattan in wave 1. The difference of Queens and Bronx with Manhattan was smaller in wave 2. But interestingly to see in Staten Island, a predominantly lower income Republican area, the rate of COVID-19 cases and deaths per capita become more pronounced in wave 2. And we think this may be explained by plausible exposure to misinformation about a disease in Staten Island. So we also found neighborhoods that were most severely impacted in wave 1 were also more affected in wave 2. Neighborhoods with a higher health insurance coverage rate have a lower death rate per capita and case fatality ratio in wave 1, even though these neighborhoods have a similar rate of COVID-19 cases compared to the other neighborhoods. But such disparity was not observed in wave 2. Neighborhoods with a higher percent of Black population had higher case fatality in both waves. And we think this can be explained by the inequality in access to quality health service, because in New York City, health insurance rates are very high. So health insurance coverage may serve as a proxy for nearby high quality health services that enroll patients in Medicaid. And this was seen in other studies like diabetes. Black population also generally live further from medical centers. Neighborhoods with a higher percentage of Asian population did not have elevated incidence rate of COVID-19, the death rate per capita, or the case fatality ratio in wave 1, but we did see an elevated in wave 2. So the lower incidence rate in the wave 1 may be So the lower incidence rate in wave 1, we think is because they get information from social media, because the COVID will first happens in Asian and then come to US. So the local community already have a knowledge about they need to protect themselves. So that's the reason we didn't see the elevated incidence rate in wave 1. We didn't see the elevated incidence rate in wave 2 as well, and this may be explained by higher adherence to mask wearing among Asian community.
Dr. Chen, I just want to be cognizant of our other speakers, so if we could.
Okay, I will only 1 minute and close up.
Sure.
Okay, so I will talk about the conclusion slides. So this study really shows spatial disparity in COVID-19 incidence and mortality across the New York City neighborhood were dynamic during the first 2 waves of the outbreak. And the lower median household income, as we show in the analysis, was associated with a higher rate of COVID-19 incidence and death rate in both waves. Also, neighborhood with a higher percentage of Black and Asian population had a higher case fatality ratio in wave 2, even though the incidence rate did not increase. So this is our paper. It's just appeared, and if you have interest, also you can email me. I can send you a copy of the paper. So this is my email. Thank you.
Thank you very much. And I would have to really commend you. You did a very simplistic job of explaining complex methods. And I really applaud your effort in that. Very interesting work.